it as well.
Yes.
Yeah, she and I were the two nurses there in the entire thing. So
Only one
Yeah.
nurse back then, yeah, only two. Oh, ja.
Mag ik een voorstel? Ja, wil je een heel voorstelrondje maken?
Nou, ik zou zeggen, laten we vooral beginnen. Voor de rest kennen de meesten elkaar.
We're talking about we all introduce it to you, but we are starting.
Yeah,
Yes.
so take it away.
Yeah, let's start.
Okay. Well, Sean and I are going to go back and forth a bit in this presentation, but I think that the good place to start is to tell you a little bit about my background and how we ended up where we are today. So a few years ago, I am a nurse. I'm a nurse practitioner by training, and I started a company. And at that time, when I reached out to every nurse that I knew who said, you know, I'm ready to start a company, I got radio silence on the way back. And if it hadn't been for what I would consider random moments of luck where I connected with entrepreneurs who said, you know, Rebecca, actually, you're on to something here. Like, stick with this. This could be something. I knew that I probably would have failed. And so I ended up attending what is called a hackathon. Do you have hackathons in your, you do, all right, so you're familiar with the concept. I ended up attending a hackathon at a medical school out here in Boston. And when I arrived, I realized that I was the only nurse at that event. And as the event went on, I felt very challenged to stay, but decided to stay, and our team came into second place. And at that point, I started to dive into research to understand the medical hackathons going on around Boston. And what I discovered was that although a very small number, less than 4% of attendees at medical hackathons across Boston were nurses, almost all the teams that went on to win had nurses on their team. And what that said was that nurses had a true level of application that made the products and the pitches valuable in a way that those that did not compose of teams that use nurses on their teams. So randomly, I picked up the phone and I called Dean Hanneran, who is my boss at Northeastern University, and I said, I believe that we should have a hackathon for nurses. And she said, well, that's interesting. I am running a summit on innovation, entrepreneurship, and nursing. Would you be willing to run a hackathon for nurses? And I said, well, I attended one, so certainly I can run one. And we developed in June 2016 the first summit on innovation and entrepreneurship, followed by a 2.5-day hackathon in which groups of nurses from around Boston attended, with over 200 in attendance. And from that point, we have been building ever from there. So that's a little bit of my background. And Shauna, do you want to tell them a little bit of your story and how you ended up where you are?
You know, it's interesting when you try to figure out your origin story, you know, which are those moments of epiphany. And I shared earlier the one about the $1 million hip. I think that that was a paradigm shift about how to really think about healthcare. But I think my accidental entry into entrepreneurship came from the standpoint of the unit that I was working on. It was at Georgetown University Hospital in Washington, D.C. And it was an interesting inflection point in healthcare. So at that point in time, when I first entered practice, healthcare was predominantly run in the U.S. by faith-based organizations. So it was mostly nonprofits. It was a physician-centric model. There was no word like patient engagement. And we really didn't have much in the way of a business model innovation. There were no HMOs at that point in time. Kaiser actually hadn't really even gotten off the ground. So one of the problems that we were experiencing on the cardiac care unit that I was on was a high rate of turnover and very high, high cost for labor. And our unit, the hospital was looking at this saying, what is going on in the CCU? Traditionally, CCUs in America are the revenue generators because you come into the hospital with an acute event. We have a very expensive procedure that we do. People get better very quickly, and then they are discharged. So that is a moneymaker for most hospitals, as opposed to a lot of the critical care units or oncology units where you've got very complex, expensive patients with long stays. So what they couldn't figure out was, why was your unit so expensive? And when I started looking at it, our labor costs, what I realized was nurses like their jobs actually for their time off, not so much for the time that they work. And I came up with this idea that said, maybe part of the problem here, the reason why our labor costs are so high is because people aren't getting the schedules that they want. They don't get the weekends off that they need. They don't have the days off that they need for whatever it is. And why is that? And started looking at that problem. And what I found was that it was a locus of control issue. The nurse managers on that unit frequently would use the schedule as a tool of either incentive or punishment. If they didn't like something that you did, you got stuck on some really bad shifts, or you didn't get the days off that you wanted. And there was a lot of not great morale at that moment in time. And so I kind of turned it around and said, look, as managers, if you don't want to be accused of favoritism or whatever, or you want to encourage seniority, you don't want people calling in sick on days that you've scheduled them to be when they had asked to be, maybe you just change the model and we have a self-scheduling model. So I developed all these criteria around how a self-scheduling model would work in order to reward those people who are taking the least desirable, most unwanted shifts, which were usually weekend night. Rewarding people for seniority by saying the longer you stay on the unit, the higher up you get to be in selecting when you are on the schedule. And then put a certain set of criteria in that scheduling request that kind of evened it out to say, if you're not exclusively working nights and weekends, then you have to pick one or two of these. And those people who are willing to work the least desirable shifts, you get to sign up first. And what that meant is that it blocked out the least desirable shifts. They had the greatest amount of control. Anyway, developed this model and we put it in place. And within about 3 cycles, billing cycles, we had dramatically dropped our costs for labor. And not only that, satisfaction went way up. We saw a lot of reduction in patient error because we weren't calling in nurses that were on an on-call pool and weren't used to working on the team. By every measure, this was a really big success. And I recognized at that moment in time, this was a nurse-driven innovation, and it came from the fact that I was close to the problem. I understood what the problem was, and I was able to define it, and I was able to come up with a solution that met the needs of patient care and safety, the satisfaction of the providers, and the financials that the hospital was trying to achieve. And the other part that we put in there was, if we can meet our goals and save the hospital money, can we not turn around and reward our nursing staff so that you get increase in your pay? So we went from being the unit that had the highest turnover to the unit that had the lowest turnover and the one that everybody wanted to work on. So that was, like I said, my accidental, I didn't even know what the word entrepreneur was, and I certainly hadn't come up with the concept of entrepreneurs. But that was, the early stages where I recognized that if I had a little bit more understanding of what it took to succeed in business and business models and building a business case and understanding that a problem isn't an opportunity to complain. A problem is an opportunity. It's a business problem waiting to be solved. And you need to bring teams around you to help you figure out what the actual problem is and what are the financially sustainable ways to put something in place. So that's, like I said, just a little bit of my, early stages of how I tripped into entrepreneurship.
This interactive for you guys from this perspective. So I think the question that we would like to understand from you is, in your words, like, what does innovation and entrepreneurship mean to you?
Yeah, I'm curious if any of you guys have some good stories that you want to share. And I'm sorry, neither one of us speak Dutch, so thank you for being such great English speakers.
Angeline, do you know any examples of any of the others? Of nursing innovation stories?
Yes, I think there are some of nursing innovation stories. What we don't see, I don't know if it's about the Netherlands or to do with nurses, but the entrepreneurship, I see less. But I do see innovations. In ICU, a nurse developed a new tool for patients who are on a ventilator to communicate. There are nurses who are now call themselves e-nurses because they communicate through Facebook with patients. But it's not only that, that is what they are doing, but they are also helping patients to learn how to communicate, how to work with this computer, how to, also learning the doctors. So it's not scary, and you can do this, and so it's, I don't know, it's what nurses do. I think it's not to say, hey, this is something I made or something I do really great, but I want to implement the tools and try to get the patients and the hospital ready to use the tools. So, well, delivering care is getting easier. So that are most of the innovation nurses I met. But it's not easy. It's not something. They are not the first people where the organization is thinking about when it comes to innovation, or when it comes to how do you say, invest in innovation. It's not automatically, oh, I have to invest in nurses because. But I also worked some time in home care, and these were not real technical solutions, but they were really innovative. How you can help people in their own home. And
it's interesting that you would say that they're not, the high-tech solutions. And what I love to share with people is that what most of the times nurses come up with are the really practical solutions. And what I love to tell people is that my colleague, Daniel Kraft, he lives on the cutting edge of technology, and I live on the cutting edge of common sense.
Yeah.
So from the standpoint of, again, where there's, to your point of, it's not something that happens an awful lot. I think part of that is that within the systems, it's not encouraged, it's not measured, and it's not rewarded, mostly because if you look at healthcare finance across the globe, what you see is within systems, our physician providers are a source of revenue. When they admit somebody to a hospital or to a medical care facility, that generates a revenue stream. Nurses, social workers, pharmacists, physical therapists, everybody else on the team represents a cost center within those enterprises. And so just pure, simple business stuff, you want to maximize revenues and you want to cut costs. So we don't necessarily think about investing in our cost centers. We're always thinking about how do we reduce them or make them more efficient, replace them with something that is less, that has fewer friction or the human elements. So we just don't think that our system has really been designed to capture the insights. And again, I think one of the reasons why a lot of the nursing innovations tend to be on that practical side is just being so close to the problem, frequently not only close, but to its very earliest stage. When you catch something in its earliest stage, that's when the complexity of solving is so much lower. So the complexity and the cost, so you can see it coming up. The thing is that nobody really gets excited about the things that happen. We love, all this training where there's the adrenaline junkies in us, where we love to jump in and save somebody's life, as opposed to anticipate a fall and making sure that fall doesn't happen. So I think that there's just kind of, a psychology and mythology, a business model. And this is, from the standpoint of looking at healthcare systems across the globe, this is what I've seen. And the only places where a prevention model or things focused on community health workers or nurses, things that are along the lines of health education and health, the wellness and prevention training, the places where this is embraced are in communities that are very resource poor. And one of my favorite examples actually is Cuba. If you understand what has been going on in Cuba, they just have had zero in the way of infrastructure. They've had to rely on the fact that if they're going to reduce any problems across any healthcare a disease spectrum or a sector of health and illness, they have to do it on the prevention side because they cannot afford to treat people who are sick. So why do they have such amazing outcomes in the maternal child care? Man, they are on it from the get-go. So I think that's, if you look to the places that have been very, very resource constrained, they have every single person working at the top of their skill deck, and they start down at the earliest stages of some type of healthcare intervention and look at those groups of folks and say, what can we do to make sure that we don't have the more costly and complex problems?
And I think when you look at nursing education, and I think there's basic fundamental principles. Nurses have been told that they have two things in life that they shouldn't do. One is to harm a patient, and two is to kill a patient. Is that the same in principles in over where you all are?
Hope so.
That is like a basic fundamental, but when you work in that kind of environment, that means you follow protocol. That means you don't challenge authority. That means that you don't innovate, because innovation can lead to problems. So when you have a fundamental principle in nursing education that is to follow instruction and not challenge the status quo, suddenly the status quo eliminates the ability to innovate and be an entrepreneur. Does that resonate there? So that is some of the work that we're trying to do at Northeastern, which is a challenge, because how do you break down an industry that basically teaches to an exam, to a licensure, that you have to make sure that you have the fundamental principles and the clinical skills so that you don't kill or harm patients, but allows enough flexibility so that innovation and entrepreneurship can take place and take root. Because in our nature, you give a nurse a roll of tape and they can MacGyver with anything. I can see nurses, they basically cross that threshold, and if a device is not working for them, you give them a roll of tape and they're going to make that device work for them, but they don't recognize that as innovation. And I think that if we move forward, how many of you recognize who this person is?
Lawrence.
That's right. Florence Nightingale. So when I was in nursing school, I was very tired of hearing about Florence Nightingale because I didn't understand who she was. So after years of being out of nursing school, I went and looked up really a little bit more about her principles. So I'll tell you a quick story about her. And Florence served during the Crimean War. And at that time, she was on the front lines of the battle, and she was watching the British troops bring in their injured into these large warehouses where disease was spreading rampant from patient to patient. And she identified that patients were not dying from the injuries they sustained on the battlefield, but were dying from what appeared to be diseases that were spread from one patient to the other. And in that, she came to the head of the control units, and she said, I believe something needs to be done. And what did Florence Nightingale identify that has changed the future of infection control that still to this day has not been amplified?
Wash your hands.
Wash your hands. She went against a system that for centuries had always believed that germs did not exist, and that the ability to spread disease from patient to patient, that these were just ghosts. She challenged status quo. And the truth is, for innovation to succeed, there needs to be that ability to take these ideas to the next level against conventional wisdom. And so Florence said, I attribute my success that I never gave or took any excuse. And I think that's the truth when it comes to innovation. I think that there is a desire that you're going to have the ability to fail and fail hard and fail again before you have success. I knew we didn't have a chance to run through these, but any thoughts that you have there too?
Can I ask a question?
Please.
Looking at entrepreneurship, is one side is ability to see the problems and being pig-headed enough to actually tackle those problems, and the other side is having a system in place that embraces that change to happen. Looking at one side, the nursing education, how do you facilitate or stimulate nurses to have a different mindset and to look at problems as an opportunity to change?
Sean, I'll let you start and then I'll jump on in.
Yeah, I think mindset is fundamental in all this, and there really needs to be a paradigm shift. And part of this comes from, I think, at our most senior leadership levels, right up at the very top. If nurses, if anybody on the team, and we're focused on nurses, but I am really a big advocate that health is a team sport. So I just want to make sure that you understand that I'm just using nurses as a proxy. And one of the reasons I use nurses as a proxy is that we're trying to solve so many healthcare problems on the backs of the smallest percentage of our healthcare workforce, which it tends to be physician driven. They represent about 5% of the global workforce. So that just a numbers game. So I just want to make that really clear. But it comes from an attitude and a mindset up at the senior levels of leadership. And when they have this mindset of, we gain insights from across the entire care system, the entire patient and provider journey, what they do is they're providing cover. And that's the biggest piece. They are not driving the innovation. They are supporting those folks. And it's not even so much innovation as it is problem solving. And we need to talk about, what is the definition of innovation? But if you don't have that level of support, you're not going to be surfacing it. you're not going to be acknowledging it. You're not going to be rewarding it. You're not going to be setting aside time for it. You're not financially paying for it. And I think that those are, if you want this to flourish, a lot of this starts with the senior levels of leadership to be able to prioritize and then set aside the safety zone for it to be done, the time for it to be done, the collaboration points for it to be done, and the financial support. And a lot of that means, if you've identified a problem within your unit or your system, whether it is people are missing their appointments, people are falling inside of the hospital realm, or in their inpatient experience, people aren't picking up their medications, there are a lot of medication errors, whatever those problems are that you've identified and you want to work to solve. If you don't set together, if that senior leadership doesn't say this is something that's going to change, it becomes an uphill battle. And it becomes an uphill battle from the standpoint of somebody who, what I like to say about innovation, the mother of innovation is frustration married to a financial opportunity. That's, to me, where I see where innovation actually happens. Somebody gets so frustrated and fed up, they're like, I'm going to go do something about this. And then their pathway is a continual uphill battle and obstacle removing exercise. What might that be like if we flip that around and we had senior level leaders to say, these are the problems that we've identified. Who in our community, in our care system, needs to be involved in helping us to understand the root of the problem, and then coming up with a solution that's going to work and really understands and appreciates the financial realities and the workflows and the people involving this. And too many times we are not engaging our patients, the people who are the experts at having that particular problem. So I'm hoping I'm answering your question, but I think a big piece of this comes from, at the executive level, a prioritization and a recognition and a comfort level that maybe the word is safe experimentation. And sometimes there's a language piece, because over in the disruption and innovation economy, we talk about fail fast, fail forward. I don't know about you, but every clinical environment that I've ever been in, failure is not okay. If you give the wrong medication, you're treating the wrong patient, this is not okay. So that's a language, and I think we really need to find the language that feels comfortable for people innovating on the clinical space, and so that we know where the safe places for us to experiment and what type of experimentation can we have. But again, I just really go back to, if it's not supported at the senior levels, at the executive levels, it's an uphill battle. And boy, does it change when you've got support and cover to run with really looking at how do you solve problems.
I think it's, Shauna hits the nail on the head. And I think we're doing this right now, right? We're trying to figure out how we change education for nurses in an environment where a lot of people wonder if entrepreneurship and innovation is a fad, if it is something that is sustainable, if it is something that is worthy that nursing should consider, because nursing is based on fundamental principles of clinical. And so if you want the answer, we're basically throwing the kitchen sink at the wall, and you'll see the list of events that we do. But my idea is, or our idea is that you throw innovation events at nurses at their earliest moment, when they are students. And suddenly you do events when they sit there and say, I haven't been on a hospital floor where I have been beaten down and told, do not step outside the box, do not challenge the physician's authority, do not challenge that protocol. But when they're in nursing school, when they see the potential of where the problems where X and Y don't necessarily lead to Z, but can perhaps lead to A to get all the way back around the circle. These are the chances that you have to actually do things. And it's creating that environment, like Shauna says, that gives people the ability and the time to think differently. Nobody can sit in a room, if I said to you right now, we're going to try this, but it's very hard when you have a problem staring you in the face and you have 6 patients that all need different medications and that you're trying to solve that problem to do anything with it. So you have to start it early so that nurses know that they have the ability to do this. And then you have to establish the places and where they work to know that they will be given the resources to do that. So I think that's a really good question. And you also have inherently in nursing this belief that you have to play to the fundamentals, and how we can bring entrepreneurship and innovation thoughts into it largely is not going to start with curriculum, because that will be seen too drastic. It's small baby steps of introducing and showing success cases out of that I think will change the overall landscape.
Can I also comment?
Please, please.
Yes, because you're saying, and it's true, nurses need to be facilitated, but they also, what they can do themselves, what I've experienced for the past years, show them what you got. So show them your skills, show them your competence, and then you show them so much they can go around you. It's not all about sitting in your chair and waiting until your manager's saying, hey, you go and innovate, because it's two-way around. You have to show what you're doing. You have to not be so modest, but tell and well, make yourself seen and ask for that support. And when some nurses start doing that, it can go on for every nurse. But my experience also, some nurses are just some, not all. So I don't have the time. My manager doesn't believe in me. I don't have the skills. Well, that's not helping. So it's both ways.
Do you have some good examples of how to organize that kind of energy? Because we had some discussions that we both work at this hospital, and we have about 1,700, 1,800 nurses here. So once we had a discussion about nurse leadership, and I said, well, if 1,800 nurses start to roll, everybody will hear this. So why doesn't it happen? You have 1,800 voices. If you get organized, you will change. You will change how it works. I don't see any limitation there, but the thing is, how do you get them organized? Because somehow it just doesn't really happen.
Lucien, I actually do have a couple of examples of where that works. And I do also want to focus on, I believe that there is a DNA for entrepreneurs, and I actually don't think I have it. I think that I am the entrepreneur's very best support. I'm like their biggest fan and cheerleader. But it takes a lot of courage to an entrepreneur in any sector or any background. There's a certain amount of courage because you will fail. Things aren't going to work out, and that's a great space. That's an incredibly vulnerable spot. So I think one of the things that's really important is to figure out within your organization, within your group, who has the DNA and who has the fortitude and the tenacity to really be that entrepreneur. There's a lot of fearlessness that goes on with that. And part of some of the exercises that I've been a part of, which have been different innovation challenge or hackathons, what's quite interesting is to see the different types of personalities surface. And so one of the examples that I wanted to share, and Rebecca, is this a good time for me to share?
Yes.
So I'm in Austin, Texas, and you've probably heard of this small company called Dell Computers. A lot of stuff around here has the Dell name on it, and one of them is the Dell Children's Hospital. I worked with a group that was a competition management platform called Verb, and their focus is innovation challenges. And the major reason why a lot of companies do innovation challenges is that they are morale builders and capacity builders. It's not so much finding the solution, it's creating teamwork. And I presented this to the Dell Children's Hospital because they kept having a fair number of, children's hospitals are complex because the patient is generally below 18. The people that you are taking an awful lot of care of and interacting with are the parents. So it just adds to the nature of the complexity. And they kept having a fair number of problems, and they were trying to figure out how to solve them. I said, why don't we do an innovation challenge? And I'm not looking at this innovation challenge as a way to come up with all of the point solutions. What I'm looking for is how do we use this exercise to surface the people who are the natural leaders and problem solvers, and to identify those problems that maybe the senior leadership isn't seeing at its root cause. And it was incredibly valuable because, like you said, Lucien, this was a large group of nurses and they opened it hospital-wide. So what was interesting is that the hospital was surprised to see that the predominant participants in this were nurses. And then there was this range of, and interestingly enough, they had the dietary aides. There were the folks who were doing the room cleaning. There were the greeters and the folks answering the phone, who identified a lot of the problems where patients were missing appointments or follow-through, prescriptions weren't getting to pharmacies. a range of problems that led to a lot of readmissions for the hospitals. But what they found in this exercise is that there were a certain group of the nurses who were very comfortable in identifying, very capable at identifying what the problem was. Then there was a different group of nurses who were very good at organizing everybody to say, well, here's what we need to have. We need to have somebody from admin. We need to have somebody from procurement. We need to have somebody from IT. They figured out what the resources were that the ingredient list of how do you actually solve this problem. And then you had those folks that were more the program and the project managers. They were the coordinators. They were able to bring everybody on time into the team and sequence what they needed to do and share it out and keep everybody on track. Then you had folks who were really good at running the numbers and figuring that out. And then you had the natural salespeople who could go and pitch this to the administration or to whoever it was that they needed to get buy-in from. So that exercise, where you list it as an innovation challenge, it might look on the surface like we are trying to come up with the exact solutions. What they found a couple of months afterwards, and then it's been 2 years out, that has spawned a culture. It's changed the entire culture where folks look at problems and see them as opportunities to work together as teams. So I do think from the standpoint of there are several different examples, and to your point earlier, from the standpoint of not asking for permission, one of my colleagues, he tells me all the time, be bold, proceed until apprehended. It takes a certain amount of I think that the place where any clinician is strongest in their innovation is when they know their clinical piece solid. And until you get your footing, I think in the clinical realm of really understanding the clinical side of care and the clinical side of the process, once you have that down, it makes it a lot easier for you to feel really comfortable in identifying the problem and then just boldly going and doing things that feel uncomfortable and somewhat dangerous to your career. And I think that that's where you find those champions internally to say, I've got this problem that I'm working on. Who do I need to go to? And gathering a team of support and champions. And it does require, I think particularly in internal and systems, it requires an awful lot of teamwork. I think it's really hard to try to go this on your own.
All right, I think we'll keep going on to give you guys an idea, a little bit of the scale of nursing and what it looks like today. So around the world, we have about 19.3 million nurses worldwide. In the United States alone, we have 4 million. And I told you before when we made the introduction, we're looking at the average age of a nurse. It's 55, and 50% of our new nursing graduates in the United States are leaving the bedside within 2 years of practice. Those are horrific numbers for the United States. We're facing a shortage of over 1 million nurses by the bedside. We at Northeastern University on average used to admit a class of 90 incoming freshmen into our nursing school. Based on our SAT scores, that number on average for our freshman class is down to 19. That's because our university is improving to one of the leading universities in the United States. Our SAT scores are so high that actually we had 4 valedictorians that joined our nursing class, and that's the competition to get into the school. Now, we will backfill seats to get back up to 90 for year 2 from people that would transfer. But as you can see, the problems that we are facing in nursing education and attracting the young into nursing is a problem. Are you seeing the same problems where you are?
Yeah. I work in elderly care in the nursing home, and as it comes to nurses, I think we have enough till a bit shortage. But the caretakers, the ones that are allowed to give out medicine, who are not a nurse but just one level below that, nobody wants to work in an elderly home, and we're all fishing in the same pond to get people to work with us. So that's a real problem up here.
Well, I didn't know, one, that you were allowed to give, in the United States, to give medication. It is regulated to nurses at this level. There has been a big debate going on to deregulate that, especially for nursing homes and home care. But you're right. I think, and why do you believe that, what do you believe is the driving force because nobody wants to work in those areas? Why do you think that is?
It's not sexy to work in a home for elderly.
And how is your pay? How is the pay rate?
Not that good. You're better off working at home and home care. But then again, the schedule in home care is different from, so it depends on your own, your private life, what you want to do. But we see that in home care, we get people faster than in elderly care, elderly home.
I think there's somewhere a real connection between the innovation path and how many nurses you have, because you only need so much caretakers as how big the demand for care is. So if I went to a conference not long ago that was about education system for the ICUs and the critical care, and everybody was talking about how much people we need to educate to get enough nurses, and nobody talked about how we could diminish the demand for care, because I don't see any downside if less people get driven with sirens to any emergency room. So the thing is that there is some intersection between what we need innovation or better, that we need a different approach, not per se only innovation, also a different approach, so we get to really advocate prevention instead of making it better, and then downsizing demand as well, because if you only tweak one or not, it seems like an endless pond that you keep throwing money in.
I was going to say, I think, Lucian, one of the real values of innovation and bringing nurses into this is that frequently we're solving the wrong problem. And a big piece of this is to redefine it. So it's not, is there a shortage of nurses to work in elderly care? The problem is, why do we have people who are so sick? Why are they not having a higher functioning life? And one of the leading questions that I use in the venture world is, so one of the things that I do is I spend a fair amount of time with startups and with venture capital groups and figuring out their investment portfolio and looking at deal flow. And I ask them all the time when they're looking at something, if they want to invest in it, I ask them, are you investing in sick care or you are investing in health care? And the litmus test I use is breast pumps versus insulin pumps. So they're both devices that are worn on the body. They're both looking at somebody's homeostasis. One is health creating and the other one is chronic disease management. And what we're saying with the insulin pump every time we invest in is like, don't worry about having diabetes. We're going to make it really convenient for you. That's an investment in sick care and people with this perverse incentive for people to be sick. And so if we keep investing in that, then of course, I mean, why does Big Pharma want to stay where they are? And late stage and end stage of every disease, that's where they're making a bunch of money. They don't want to shift their attention. But imagine if you start investing in healthcare and redefining the problem, and you put that same level of resource into breast pumps, and we make sure that women are able to breastfeed their babies, continue on in their life, their work, and their lifestyle that they want. That's an investment in health. And to your point, Lucian, a big part of innovation is making sure that we are defining the right problem and solving the right problem.
Okay, one thing, I'm not Lucian.
Oh, I'm sorry. You look like Lucian in the back. I have to say, you look like 3 pixels. Yeah.
My name is Remco. I think I heard one of, in the talk, I heard somebody say, if we applied the same, let's say, reward system to our firemen, the entire country would be in flames. Basically, yes. Because you get paid to put out fire. So you literally set fire, that's what you do. And but that's moving away from what one person or 2 or 3 or 4 can do, because we can also always look at the system. So, and that is the most intriguing part, because the system is really not, there are not a lot of, I think the system change comes when the people really say we've had enough, because it will try to maintain itself again and again. It's like a hungry monster that never gets enough. So how do you get to one, to just from 1 to 2 to 3 to 4 to 5? It's even difficult in one hospital because we know where we are, so we know the people. It's not difficult. And still, it is very difficult. it is very difficult to.
I think we know the reality in nursing homes and the struggles that are facing nursing and our nursing administrator is staffing. We know that they're always short. We know that scheduling is always the problem. It's the boots on the ground that keeps, the operations running. And when it's the difference between giving time off for somebody to innovate a new device or a new methodology versus having somebody by the bedside caring for patients, it's not something that is ever going to win in the former. And I think that's the challenges that we face. And you're right, it's a systemic problem. And the truth is that it's perpetuating itself by less going into nursing. And that's why they're like, we need more educators. But the truth is, it's the system. And if they created a better system by which caregivers and nurses could work, suddenly you would see that people would go into nursing and the systems could be improved. As you have a system that keeps driving down those that are working in it, the systems are going to further break down. So I think you're absolutely right on that problem. And it's going to be those with the greatest foresight into what is coming down the pipeline to realize that they're going to have to make very hard changes and significant cost investment into their nursing workforce to lead these changes. And I think that's, you guys are hitting the nail on the head. But it's only going to get worse if, as they say, right, the definition of insanity is to keep doing the same thing over and over and hope for different results. And that's exactly how we're facing the problem today.
Can I have a question about your entrepreneurship or nurse entrepreneurship? How do you change the mindset of the nurse? Is it a part of your program? How can you go to prevention instead of I help you get better or comfortable in your situation? Because I think it's a really big part of the system, the nurse. So can you change there?
I'm going to jump around, absolutely. So do you mind, Sean, if I jump around for a second?
No, go ahead, yeah.
So when we started this process, we had no idea what to do, right? Because we, by the status quo, were being pushed back by the majority of those out there that said this is not something we should be doing. And so we took the idea and the route that since we can't change curriculum right away, we are going to bring entrepreneurship opportunities to nurses. And we had that through a university. So in the course of a year, from the time of June 2016 to July 2017, we put on 14 different events to meet nurses at every level of their spectrum and at every stage of their entrepreneurial journey. Those that had never thought about entrepreneurs or innovation, which we held a summit. The summit was on the pedagogy of how you create innovation entrepreneurships. Actually, Shauna will be coming out and speaking at our next summit in September 29. And that was just to sort of get the high level managers to understand why it was important. We then offered 2 courses on Hackathon that were just basic business courses to see if nurses that had attended these events wanted to understand what is a financial model, what does it mean to be operational, what does business 101 mean, because nobody's ever showed me what an Excel spreadsheet looks like and why patient satisfaction scores in the United States drive down my reimbursement so that I can hire more staff. We then started to feature nurse entrepreneurs and innovators. So we brought a woman by the name of Hiam Nadel, who's the the head of obstetrics at Mass General Hospital, which in the United States is the #1 hospital in the country. And she is a nurse innovator and entrepreneur. And we featured her and brought nurses to hear her story. Suddenly, the tide started to change, and we had Mass Challenge, which is an incubator in the state of Massachusetts. Is the digital health arm, invite a group of nurses to engage with their technology companies early on to say, here's what I would do as a nurse. And this product I know you think is great, but we're not going to use it the way you have designed. Then Mass General Hospital, for the first time ever, invited us to go and talk to their nurses about what we were doing. And then we re-engaged again with a hackathon. We did lecture series. IBM reached out to us to send nurses to their event. We did a telehealth conference on the future of telehealth. And then we also did a nurse practitioner entrepreneurship conference to start encouraging nurse practitioners to start their own businesses. Not every event was what I would call a roaring success. There wasn't hundreds of people at every event, but what it's done is it paved the pathway. And that was where my boss has been so instrumental, similar to what Shauna was saying, is she has given us the space and the cover to run this. And it has made it the priority at our university. I am not a professor. I am solely given the time to build these events. I do teach other courses, but the idea is that for this to be successful, it had to be a complete commitment by one person to sort of lead that. Does that help you? Does that sort of answer some of the questions or help or give you a roadmap?
and actually I wanted to offer a couple of other things. So the question that you ask is, how do you change the mindset of the nurse? And I will say that within my peer group and set of colleagues, sometimes we are not our biggest or best champions. And I do think that there is a mindset piece that needs to happen. And I think it's possibilities that are shared, like where can you actually do that? And specifically, the domain that nurses really are best at is education, prevention, and wellness optimization. That's really the domain that we excel at. And so one of those things that I've done, there are 3 different areas where I try to open up that aperture for nurses to change their mindset about and see themselves as an entrepreneur. So one of them is all the startups that I work with. If they are working in the health space, the first thing that I ask them is, what are your clinical needs? Because the first thing that they think that they need to do is hire docs, or if they are trying to pitch their product or their service, they want to go right to the doctors. I'm like, if you really understand this, you'll understand that nurses are probably going to influence a lot of those decisions and are probably going to give you the level of clinical understanding that you need at a lower price point. So particularly for startups, when they've got their burn rate, if they want to reduce that, they're going to be a lot better off hiring a clinician that's a nurse from a financial standpoint, but then also just a broader group of people to advocate and to understand what their product is. So that's one area where it's been pretty successful in changing the mindset of the nurses, is that I'll introduce a couple of these startups to say, let me introduce you to this nurse who's over in the CCU, one that's in the NICU, one that does at-home care with hospice. So that's a big piece of it. The other part is that if you take a look at any innovation team in a hospital, the vast majority of those innovation teams are staffed not by, or teams led by, there aren't nurses in those circles. There aren't nurses on those teams. So that's where I go back to a lot of the nurses and to say, find out what's going on in your innovation agenda, see where you can be a part, and then to challenge a lot of the innovation activities at different hospitals. How many of your team members are nurses? How are you engaging them? And then the other part is encouraging entrepreneurs to look at, when you specifically changing the mindset of the nurse, and to focus those efforts on prevention. The biggest piece of this is, the way we finance healthcare around the world is quite different. A lot of innovation gets driven by the U.S. market, and we have an insurance system that really drives a lot of what happens here. If it's not reimbursed or covered by insurance, then it doesn't get innovated around. You follow the money, and that's where you're going to see where everything. And that's true when you go into systems that are single payer or state run type of thing. So what I look at is that individuals will spend money, their discretionary dollars, on things that add value and remove friction in their getting the outcomes that they want. So if you take a look at what is it that's a real pain point for a patient, so whether they've got COPD, it's a newborn, it's a fragile child, it's somebody with cancer, what are those things that people are willing to pay for because it makes their experience better? That where you start tapping into discretionary dollars, those are generally opportunities for nurses to innovate around and to lead businesses. So that's one of the areas that I encourage them to look at to help them change their mindset. They're probably not going to set up freestanding emergency departments or freestanding birthing centers, although I have seen a couple of nurse practitioners and nurse midwives who are doing that. But starting at, like, where are the opportunities that people would use their discretionary dollars? Where do you go in and help provide those services? And a lot of that has to do with navigating a very complex set of care. Do you have somebody who can help you understand, I need to go to this person for this, I need to see this, and to help coordinate that, particularly as the elderly live farther away from their family of origin. Their family of origin, particularly their adult children, are looking for that support. This is a brilliant place for businesses to thrive, that the skill and the training of a nurse is exactly an appropriate level to build a business around. So those are some of the ideas that I have, and where I've seen some success in getting nurses to actually start thinking of themselves in a different way, and how do they take their skill set and maybe use it in more entrepreneurial fashions.
Sorry. Yeah, well, I want to add to that. Well, I was lucky to have Reshape in the own hospital, because what gave me energy was connecting to more technical people. Well, I see problems or things that don't work, but I don't know everything that's possible. Maybe now I know more. But these startups here at Reshape, they think they know a lot of patients, but they don't really know. So they were really happy to talk to me, and I was really happy to talk. And then you get some energy flowing, and you recognize, well, I know a lot of things a lot of people don't know, and it's worked also the other way around. Because they know a lot of things I don't know, and it's when you put those two groups together, well, it's for me that was the turning point. It's like, okay, that's the way it goes, because we still are nurses. We know a lot of healthcare. We know a lot about patients, but I'm not a technologist. That's not my main job. But it still works.
That's why we love people like Robin, who can bring it all together. And my other people that are favorite people to me, I love people who like to make spreadsheets. I love to work with them, but I do not like to create them. So yeah, figuring out where you're the subject matter expert, and then finding those things that you don't know, or you don't want to spend the time to know, and finding that other expert in that.
And I know we're cognizant of time here, so I think we're supposed to go to questions. Is that the good time, Robin?
Well, you have about 12 minutes left, so you can spend them however you like. You could do a round of questions, you could do some more slides, whatever you want.
Is there any
question at least?
Yeah, I have a question. Do you see the position of nurses within the health innovation space to be symbolic of say, how also the position of women within the health innovation space? Because like technology, digital health, so very male-dominated, and also entrepreneurship. Do you see a connection there? And do you see that improving?
I do.
You're seeing more men as entrepreneurs in the nursing space?
No. I mean, just in the health innovation space in general.
You know, so far, interestingly enough, all of our teams that have gone on to, so we have had preliminary patents going on, and business formations have been nurses that are women. Now, what we have found is we've had a lot of men entrepreneurs come with business ideas asking nurses to join their teams at our hackathons. And that is something that is very interesting. I do believe that the mindset of an entrepreneur means that you have to have a business mindset. And as we start to identify this, as I've been talking to more nurse leaders, they said the one thing that hurts nurses the most is this emotionality. We always speak to I feel, I need, I believe. And in the world of healthcare business, the words of I feel, I believe don't have credit. You have to speak to numbers. So the truth is, it's almost recreating the mindset of nurses to sit there and understand that the beliefs that you have to be substantiated with facts, and how we bring those two together so that women can better articulate the cases that they have before them for reasons of change are significant. So if you want to do a skill set that could support your nurses, educate them in understanding how to explain things without using the emotionality behind them. Does that make sense?
A big piece of that is the difference in how do you build a business case, because oftentimes when problems are identified, it comes in and it sounds like you are a mission-driven nonprofit. And most of these enterprises, there is no such thing as a nonprofit. Every single one of these entities is a nonprofit. A nonprofit is a business that's gone out of business, that the doors aren't open to serve anybody. So this whole concept of a nonprofit world is just nonsense. Everybody needs to make a profit. It's just what we do with those profits that is slightly different. And one of the things that I have really put forward, particularly to the venture world and to the entrepreneur world, you know, we talk about we need more women in tech. We need more women sitting on boards just because of the diversity of point of view. And what I have said frequently is, look, rather than having a gender-specific agenda around, we want to increase the number of women who are getting Series A and Series B funding, what we really should say is we want to, particularly in healthcare, well, there are two sectors in particular. If we focused on investing in educators and nurses, we would actually hit those targets for women, because those two disciplines are where we need the greatest amount of innovation and disruption, and tend to be predominantly driven by a high number of females in those professions. So I do, whether it's women or nurses or whatever, those same dynamics are at play. We don't have women in STEM. We don't have women in tech. We don't have women being women-driven led businesses, women-funded businesses. They're just not getting the same levels of funding that are men. And if we actually just, instead of saying we want to focus on making sure that there are more women at the table, if we just change that word and said nurses and educators, we would achieve all those goals. So I do think that is, and as what I've seen across the world, it doesn't matter what economy you're in, investment in women-led initiatives is really, really, really low.
And I think I want to give you guys something a little concrete so that you could do with your own teams of nurses as well. Because I think that we're speaking at a very high level and you're looking for an application. And so if you are facing a challenge with nursing, this is a mini experiment you can do and say, bring your nurses together and have them do their own challenge. Like, give me, what is your challenge that you're facing? Because in nursing, we constantly complain. I don't know about you, at least I did. I'm like, oh, we don't have enough staff. We don't have enough support. We don't have the right tools. We're always in that room of showing we don't have enough. So change and flip the model to them. Say, so what is the challenge that you are facing as a nurse today? What is it? You don't have enough staff. You don't have enough patients. What is the issue? You don't always have enough patients in our deal. So you identify the problem. Turn it back to them and say, how do you currently deal with that problem? And then you ask them, how can you make it better? What would you do differently? Or what would you create to solve that problem? You can do this in as little as 30 minutes with a group of nurses. And the truth is suddenly they see themselves as part of the solution. You are giving them the freedom, as opposed to sitting there saying, look, the system is always stacked against me. It's always, nobody's ever hearing me. If you give them the chance to actually create the solution, not only does that take your pressure off of your shoulders as the administrator, it gives them the ability to feel valued in their place. And I guarantee you're going to be shocked by what these simple processes is that they create to alleviate your biggest problem. So.
Yeah, actually, Rebecca, I was wondering if it might be helpful as just a concrete exercise to workshop it out. The group of you assembled there in the room, is there a problem that you guys are dealing with individually or as a group that maybe you want to toss out to the crowd? And just right now, we just kind of workshop it, from the standpoint of, are we solving the right problem? What resources might we engage? But is there a problem that you want to that you're actively working on or bugging you're frustrated about, that we can talk about in the last couple of minutes here?
Sean, just to jump in for a moment, we have like 2 minutes left.
Okay.
Femke, who is just outside of your screen, here on the left, she was just saying that she actually did what Rebecca just described. So
yeah, I totally recommend it. There's a project called Make Health. And I think you know it, and it's a Make Nurse. Maker Nurse, yeah. Yeah,
Annie Young at MIT. Mm-hmm.
Yeah. So there's a similar thing, or I think it's related to something in the Netherlands, a project at Waag Society. If you have time, go to Amsterdam, go to the Waag, and do a workshop there, because it's great. And I went there with a group from with my hospital, and it was amazing. Just like you said, within half an hour, everybody was energized and really, it's like they're a whole new world over. It sounds a bit cheesy, but it's really effective.
Mm-hmm. Yeah, when we were talking about examples, just for you guys to look up, you could look up the Dell Health Innovation Challenge that they did at Dell Children's. MIT did one on hacking the breast pump. And I think it was called breast pumps don't suck or something like that, something very clever. Yeah. So there are a couple of different programs. Athena Health runs one that has been very focused, a heavy participation on nurses, particularly a lot of mental health problems. But the point is that when you bring a group of people together and say, what are the problems? So, what are your pain points? And then bring a group of people together. And your 10 action projects, it sounds very much like that's the model that you're using. And my recommendation with any of those is, how do we get our senior decision makers to support the effort? Get the buy-in there and pitch them to say, here's how we're helping you to solve your problem. And anytime we're looking at this, that really is, what do I need to do to help you be successful in your role? What metric are you being measured on? And within any of those executive leadership teams, when they say, look, my metric is I am evaluated on error prevention, error reduction, all these other things. That's where you go. You find that way in. And when you can find what your leaders are being tasked with solving and become a solution to that and help them be successful, that opens a lot of doors in my experience.
So thank you, Rebecca and Shauna, for this wonderful workshop or presentation. Could you maybe give the participants in here some like a website or anywhere they can read more from what you've been doing?
So yes, and I apologize, Shauna. Shauna and I literally decided to talk about this last night. Shauna, how can they contact you? What do you want their contact?
Shauna.butler@singularityU.org. And the best way to, go look on the Exponential Medicine website and take a look at all of the different talks that are there. I think that's a really good resource. And better yet, come with Lucian and Zena. Come to San Diego and join us at Exponential Medicine. Yes.
There are two nurses from How About Going. Well, I just heard today, I found out today we succeeded. So I asked if they can come.
We're on an exponential curve. I love it.
Yeah. So it's 1, 2.
Yeah, and the other thing too is that we live stream that, and what I would encourage is we figure out how you guys do a watch event. And each one of you have tribes and communities that you are trying to infuse a mindset. And so as we are live streaming November 6th through 9th, get your friends together, get your strongest opposition and invite them, bring chocolate. It always works. Mm-hmm. Chocolate and good food and great content, but invite them to watch some of that together and let's have those conversations, and we can engage online during Exponential Medicine. But I think that's a really quick way to get people up to speed about the art of the possible.
Thank you so much.
Thank you. All right.
Het is nu koffiepauze, geloof ik. Ik geloof dat we nog 15 minuten break hebben of zoiets. Niet een hele lange. Dus pak even snel wat te drinken. De andere ruimte zitten nu nog dik, dus je kunt nu nog koffie halen. Ja. En dan ben je als eerste in de ruimte.
Thanks, Robin. We can sign off.
Robin, do you want us to join in the other room?
Oh, hoe zit het nou? Ja, ik heb van haar beste meegenomen. En dan merk je heel erg
Thank you both. It was, I think it was a good session, especially because there were a lot of questions. So you really had a topic that everyone is working on, it was cool. It reminded me of the first time we did a hackathon, actually, because we had one nurse at that hackathon, one single nurse out of 65 participants. And during the team formation, she was standing on the side, completely alone. So I asked her, well, can you find a team, or what are you doing? And she said, well, I'm just a nurse. What can I add? And well, me and someone else, we went just like, wow, what are you saying? And you can add so much to the team. And she joined the team, she won a prize, and now she's joining all kinds of projects in the hospital to she's formed a special group with a couple of nurses to talk about what they read, where they go to. So it's amazing.
It breaks my heart when I hear it. I'm just a nurse. I'm like, oh my gosh.
Oh, yeah.
You are the hardest working member of this team.
Exactly.
It's painful. And then, like you said, Rebecca and I have seen this time and time again. Once they get invited and they catch, they have a little bit of confidence, it catches like wildfire, and then they can be catalysts for so many other people. So it doesn't take a whole lot, but part of it is that the vocabulary, and this is, I talk about it all the time with exponential medicine. When you say medicine, what that means is doctor and sick.
Yep.
And it tells the rest of the world, the social workers, the pharmacists, the nurses, the physical therapists, this isn't a place for you. You're in some ways you're not welcome, you're not wanted, you're not valued. You don't really have anything to contribute here. So a lot of this is, there has to be a different language, and we start moving from doctor, nurse to clinician or team member, and we talk about it as health as opposed to medicine. It opens up the aperture, and we become a lot more inclusive. And I think that so many of the solutions, we need to be looking at data scientists, choreographers, material scientists. There is a range of skill sets that we have not been tapping into.
I agree. I completely agree. And I think that the nurses can really add something like, I'm not sure how you explain it, but like they're the cutting edge of
common sense.
That was it. I do a lot of design sessions from Reshape. And what we often see is that the nurses are actually the ones that are diving into these sessions and are really joining, because they're so practical. They can easily switch to, okay, all right, let's solve this problem, and they don't end up in timeless discussions, but they just do it.
Get it done. Yeah. Robin, it might help you in some of those design sessions. One of the things that I remind people all the time, every clinical interaction, every single one, begins and ends with a nurse. So when the patient first arrives, when you're thinking about the design thinking and the patient journey, the first person they're going to share their problem with, or why am I here today, it will be a nurse. And then that nurse is the centering and the distribution force. So they stay there, they coordinate, they figure out, okay, so here's what this person is complaining of. I need to activate the following. So they stay with the patient, they start with the patient, they stay with the patient, and then they are the last entry point in sending them to a level of independence. And when things are going right, the check-in, it's the nurse who initiates the check-in. When things aren't going right, the first person that they're contacting to reactivate the system is the nurse. So every clinical interaction begins and ends with the nurse. They stay there with them, and they are the centering and distributing force. And when you start looking at the way that activity runs, because we talk about patient-centered care, and it's really from the standpoint of what we need. And again, this is a language piece. A patient-centered care means I get to make all those choices about all those things. Oftentimes when I am sick, I'm the last person you want to ask, and I'm too tired to advocate for myself. So we need to be looking at a value preference. What would that patient value? What are their needs? How do we match what their goals and their desires and their abilities are to what we might recommend for them? But then you need to have somebody who is the patient advocate and that resource distributor. So I don't think patient-centered care is the right term. I think it's value-driven and preference-driven around what the needs and expectations and hopes and abilities, and I mean that oftentimes from a financial standpoint. These options may not be financially available to you, but it's really thinking about the provider and that care, because if we don't take care of the provider and we continue to burn them out, or we have a system that they're fighting against, they can't do right by the patient. And that's what you need, is a system that supports a process to deliver the value preferenced care and outcomes that a patient desires.
Yeah, good advice. I think it's good to mention that as well in the session. Just one more story, and then I really have to go. We want you to stay. Your hours for the day. Yeah, we'll catch up later. I really want to. But I once spoke to a patient who got a heart surgery, a couple of them. we were doing a round of questions like, what was the most important thing that happened to you in your healthcare experience? And the patient said it was the nurse that was the angel with a hand on my shoulder. Because even though the doctor gave him the treatment, the surgeon did the surgery, it was the nurse that guided him through all of it and helped him through it with his family, and he was just so grateful for his nurse. He really called it, "It's my nurse." It's so those are the stories that give a lot of energy.
Yeah. Do you know who? What is his name? Deepak Chopra. Do you know him? Deepak Chopra.
Yes. Yes.
Yeah, he's written, I forget how many millions of books the guy has sold. I was at a conference with him a couple of months ago, and he said that public health is about prevention, doctors are about disease, and nurses are about caring for people and the human.
Wow.
Mm-hmm.
That's one to put on the wall.
Yep. I was like, oh my God, that was beautiful. Yeah. It's there's a DNA, there's a personality type that is attracted to and stays. And I think one of the reasons why we have so many of our young nurses leaving at an early stage is that they do not understand or appreciate, because you can't know until you're there at the bedside, the emotional and physical toll that it takes. And people who stay there, and women, and it's mostly women, who are in a neonatal unit 30 years and continue to rock those babies, they do it from a place that it comes from their heart. I mean, there's the cognitive, you have to be able to have those cognitive skills, but you don't stay doing that hard emotional work because other than the reason that you have a calling. This is something, they're certainly not doing it for the financial compensation. They're not doing it because it's sexy. People who are in mental health, oh my God, my hat's off to people who take care of our folks who have mental health illnesses. I don't have the patience. When I see people who are struggling, I'm like, just make a different decision, please. Come on. I have a really hard time with that. So when I see people who continually work with those who have behavioral disorders or schizophrenia or dementia, God love those people who have an affinity and a patience for them that 99% of us in the population just do not have.
Yeah, wow.
Well, Robin, enjoy the rest of your conference. Yeah. Shauna, you and I got to catch up. But this was awesome. Thank you, Robin.
I know, this was great. Thank you for being such a techno genius.
Sorry.
All right.
We'll talk to you later.
All right, bye.
Bye.